topic that you will be using throughout your career. You'll get questions from your friends and relatives as well as patients concerning a reaction on their skin that they think could be due to a drug. So we'll be discussing, well, first let me ask you a question. You just finished your dermatologic OTC, right? Disorders. So you should know the answer to this. Correct. So we'll be discussing all kinds of drug reactions to the skin that include redness, swelling, itching, bumps, lumps, blisters, pigmentation of the skin, things like that. And those are generally the more mild or moderate reactions. But in the severe reactions or more serious reactions, you'll even get involvement of other organs besides the skin. And we're going to be talking about, we'll end up with Stevens-Johnson syndrome. And in that case, you get exfoliation of the skin and the actual necrosis of the skin. Those are the most serious skin reactions you're going to witness from a drug. Have any of you gone to this exhibit?
Yes.
Pretty cool, huh? Yeah. I don't know how they did that. Okay, you've already probably covered this, so this is in the way of review, and I'll go through it pretty quickly. Patient will come into the pharmacy, or you'll be seeing them in a hospital, and they may have many causes for their drug disorder, or skin disorder, not drug disorder, skin disorder. Some of the more common things are infections. There on the left is, right here, if I can get the cursor, is a staph infection of the arm, forearm. This is a fungal infection, commonly known as ringworm, because it forms these like target round lesions. And until recently, this one was pretty much gone, and that's a viral infection or measles. This photo is from 45 years ago. That's how long ago measles was a problem here in the United States with vaccination. Or with this mistaken theory that vaccines cause autism, that some parents decided not to vaccinate their kids, and so we had an outbreak last year. All right, and some other causes of non-drug skin disorders are autoimmune diseases like psoriasis, SLE, which is systemic lupus erythematosus, and atopic dermatitis, which is another way of saying eczema. Here's one that you'll probably want to print. When you go on your acute care rotations or your clinic rotations and you see a patient with diabetes, these are 7 common, not always that common, but the first one is common skin disorders you'll see in diabetic patients, unrelated to any drug at all. Have you studied diabetes yet? No. Okay. You will be studying this, and you will learn about acanthosis nigricans. Very common. It's these darkened, tan, brown, raised areas, usually on the neck, the armpits, and the groin, and it particularly strikes diabetics who are overweight. There are 6 others, which I'm not going to discuss in detail, but I just like to say this one. Necrobiosis lipoica diabeticorum, which are shiny scars, usually on the shins or the legs, that are violet in color. And there's some other sundry skin conditions that you see in diabetics, not due to drugs. Here's some more common things you'll see in the pharmacy. Somebody comes in, they got poison oak, poison ivy, so a contact dermatitis, or it could be due to a chemical. Here's impetigo. Any of you seen a child with impetigo? They get this infection on their face. It's due to staph, very easily treated. Kind of scary, but kind of easily treated. It's spread in the schools. Here's heat rash, or diaper rash, if you want to call it that. And sometimes children who are overheated from putting on too many blankets will get this kind of a rash. Rosacea usually strikes females in their 40s and 50s, and it's an inflammatory condition on the face. In fact, you'll see this kind of thing too also in chronic alcoholics. Rosacea, very common problem in females. And then you all know about shingles from your vaccination, right? What causes that? Yes. Right. So chicken pox as a child, and you're more prone to get shingles as an adult. It's just the dormant virus lying in the ganglion in the spine. What activates it? Nobody's sure. Probably when you're immune, as you get older, your immune system isn't working as well. Here's swimmer's itch, which is also called hot tub itch. It's due usually to Pseudomonas, which loves water. Here's latex allergy. Here's a child who has a peanut allergy. They've got swelling of the lips, the face, reddening, and hives all over the chest. That's angioedema in the face, and that's urticaria or hives on the chest. Very dangerous because in many cases this is also associated with anaphylaxis. And here's some insect bites and stings. All right, so we're going to see we're going to be learning some interesting things about skin reactions, and we're going to cover the risk factors, common drug classes that cause skin reactions, the common culprits. We're going to differentiate between non-immune and immune, and you'll understand the clinical significance of that when we're done, because it's different in the way we treat it. Be able to describe the morphology and the types of drug reactions, identify specific prevention and treatment strategies, and how to counsel a patient when they're started on certain drugs, identify some non-immune drug skin reactions and the common culprits, and describe some immune skin reactions, such as DRESS, EM, SJS, and TEN, which you'll learn about in a moment. And also, there's some genetic factors that are really important with certain drugs, and we'll go over those. My goal is to keep you engaged. This is, and I've heard in the past from other students that have given feedback that there's quite a bit of slides, and some of these slides are busy. The reason I did that, I did it on purpose. I put a lot of hours and work into this. If you print this out, this entire PowerPoint, take it with you on your rotations. In fact, it'll be valuable for you for your whole career. Obviously, some things will change with time, but for the most part, all of these concepts and principles and these drugs continue to cause these problems even today, 50 years after they were first identified. So this is a really good reference source for you. I've given you lots of references. Each slide has references. And you'll notice on the slides that if I put a little box that says learn, that's a fair slide for a test question. Okay, epidemiology of cutaneous reactions. About half of drug reactions are exhibited on the skin. So that's a tremendous number of drug reactions that are related to the skin. Why do you suppose 3% of hospitalized patients have a reaction? They get more drugs while they're in the hospital than they would as an outpatient. And particularly, they get more topical and injectable drugs, which are the ones that are more prone to causing allergic reactions on the skin. Now, of those skin reactions, 1 in 1,000 will be a serious reaction, which we'll talk about, and 1 in 10,000 will be life-threatening. Pruritus, which is just simply itching, without a rash, alone accounts for about 5% of all skin reactions. So skin reactions can run a full gamut. They can go all the way from mild, moderate, all the way up to severe and life-threatening. These are all the things that can influence the reaction you might get and the severity of it. And we'll talk about those on the next slides. All right, here's slide 1 you want to put to memory. See my little learn box down here? You can put the risk factors into 2 categories: drug-related and patient-related. By the way, there's going to be 9 pop quizzes during this lecture. I've already picked 9 names at random. So, and if that person's not here that I picked, I have all your pictures. So I'll pick another person again. Okay, the drug-related factors are the route of administration. This is really important. You rarely see anaphylaxis with an oral medication. Anaphylaxis usually occurs with injectable drugs, IV or IM. But topical is the most antigenic, believe it or not. And do you know what the most antigenic topical product is? Benadryl cream. Never recommend it for anybody. It doesn't work very well topically, and it is antigenic, and the person can get a reaction just from that cream. The next is IV, then IM, and lastly is oral. So most particularly serious drug reactions to the skin occur in the injectable and IM category. If the drug has a high molecular weight, what's the molecular weight of penicillin? It's over 300, 600, 800, whatever it is. You can look it up. It's very high. And these high molecular weight drugs tend to form haptens, which are drug-protein complexes. The fourth drug-related is prolonged multiple exposure. You get the drug, a few months later you get it again, and so on. Those multiple exposures make you at greater risk of developing a skin reaction. High cumulative dose for those drugs that cause skin reactions by their pure toxicity. And we'll discuss some of those. All right, the patient-related factors, and there are many. They kind of make sense. Gender. Women are more prone to drug skin reactions than men. Why, I don't know. Just is that way. Age. You as a group, in your age group, are more prone to drug interactions than the very young, like infants and 2-year-olds, and the elderly. So it's the young and middle-aged that are more prone to or more risk than the very young and the very old. High-risk patients, as you might expect, those with immune-suppressive problems like HIV, bone marrow transplantation, SLE, which is systemic lupus erythematosus, autoimmune disease, active viral infections, particularly Epstein-Barr virus, but also herpes, and asthma make you at higher risk of a drug skin reaction. Here's a key point. A previous reaction to the drug or a drug with similar functional groups, which we'll discuss in the next slide, puts you at more risk. Makes sense, right? If you've had a previous reaction, just like every package insert says, and every television ad you see for a drug says, do not take if you've had a reaction before. Genetic polymorphism in HLA and slow acetylators, and those genetic considerations we'll discuss later. And then a history of multiple drug allergies. I pulled up a patient's allergy list in the hospital electronic medical record. They had 35 drugs listed they were allergic to. And they were pretty legitimate. Most of them were skin rash. All kinds of drugs. Not just an antibiotic, not just an NSAID, but all kinds of drugs. So that, having that kind of a history makes that person much more prone to getting a reaction from another drug. So what are the main culprits? These are traditionally the drugs you see causing problems on the skin. The reaction can be associated either with the actual drug itself or a toxic metabolite, or both in the case of amiodarone. It can be due to a drug-protein complex we call a hapten, or it can be done due to functional groups. See here, this is a sulfa schematic of the sulfa molecule, the sulfa drug molecule. There are 4 functional groups attached. Drugs like the COX-2 inhibitors, which we'll study later. I don't think you've covered those yet, right? NSAIDs, COX-2 inhibitors. Thiazides, have you covered thiazides yet? Diuretics? No? Not yet. Okay, those and sulfonylureas, which aren't used much anymore, but they used to be used for diabetes, oral tablets of sulfonylureas, share some common functional groups with sulfonamide. So you would think there might be some potential for cross-reactivity between those drugs. If you're allergic to sulfonamide, you might be allergic to thiazide. Also, here's one, and we'll discuss it in more detail in the next slide, but compare the common functional group with cephalosporin, which has two functional groups, and penicillin. There's a common functional group that can make you more prone, if you're truly allergic to penicillin, make you prone to have also a reaction to cephalosporin. So, key point number one, the most common culprit are the anti-infective group of drugs. 40%, almost half, of skin reactions, drug skin reactions, come in this group. Not a surprise, I don't think. And within that group, penicillins are the most common. How many of you heard somebody say they're allergic to penicillin? There are 300 million people in the United States. 30 million claim to be, 1 in 10 claim to be allergic to penicillin. Claim to be. We'll discuss that in more detail in the next slide. Also a common group of drugs within the anti-infective are the cephalosporins and beta-lactams. High incidence of skin rashes and anaphylaxis, just like penicillin. Sulfonamides is also another common culprit. The most common prescribed is trimethoprim sulfa, which is Cetera or Bactrim, but there are some other sulfa drugs that are used that are not used for treating infection, like asulfidine. And then some of the other anti-infectives, like the tetracyclines, like doxycycline, minocycline, and the like, vancomycin, fluoroquinolones, erythromycin, and metronidazole are some of the more common ones. Yes?
If you have a patient that's allergic to penicillin and he has been prescribed cephalosporin, would you dispense? Would you give him the...
It depends. We're going to talk about that in 2 slides from now. Okay, continuing with the main culprits. Here's another big group, very common, and you're going to see this throughout the lecture. Anticonvulsants, particularly carbamazepine, lamotrigine, and phenytoin, and also the barbiturates, like phenobarb. NSAIDs, another culprit. IV contrast agents, particularly the iodinated contrast, and we'll discuss all of these. We're going to discuss each of these groups in more detail. HIV drugs, particularly nevirapine and abacavir. And then lastly, in the main group, is the antineoplastics, which you would assume, because they affect mitosis and cellular reproduction, the skin is replacing itself every 2 weeks. Your skin sloughs and new cells come out, that you would expect the antineoplastics to have direct toxic effects on the skin, and that many of them do. Capecitabine or Xeloda, which is a prodrug, it's taken orally as a prodrug for 5-fluorouracil. You haven't done chemo yet either, have you? Okay. So I'll try to explain some of these drugs because you're not familiar yet with most of them. The epidermal growth factor inhibitors are the new biologic drugs that are being developed for all kinds of things besides chemotherapy, but the tyrosine kinase inhibitors like TKAs, also called the NIBs, the generic name always ends in NIB, and those drugs are always given intravenously or sub-Q or intramuscular. And then the monoclonal antibodies, also known as the MABs, are the oral agents. Oh, I'm sorry, I have that reversed. The TKAs are the oral agents, and the MABs are the IV. Okay, the question was asked about cross-reactivity. This slide is important. This is the question you will be asked every time you run into somebody who's allergic to penicillin and they've been prescribed a beta-lactam like cephalosporin or some of the carbapenem, penicillin type derivatives. It's a very highly debated topic even to this day, and it's important for you to understand the last sentence there. So, would I give cephalosporin to somebody who says they're allergic to penicillin? I might. And the reason for that is a lot of patients who report an allergy to penicillin truly are not. Oh yeah, it upset my stomach. That is not an allergy. That's an intolerance. An allergy would be a skin reaction, like a rash. That would be more of a true allergy, or anaphylaxis, or angioedema, or bronchospasm. Those serious systemic effects would mitigate you ever using any penicillin-like drug in the patient, if there's a strong history. Plus, a lot of patients say, oh, when I was 2, I was given penicillin, my parents told me I had a reaction. What kind of reaction? I don't know. So, those people claiming to be allergic to penicillin many times are not. More times than not. And we'll discover what that incidence is in a moment. It has been argued in the 1970s, when I was first starting out in my career, we used to always get nervous about giving a cephalosporin to somebody with a penicillin allergy. We thought the cross-reactivity was in the neighborhood of 1 in 10 and 1 in 5. As it turns out, it's more like 1 to 5%, much less than it was originally thought. Now, the cephalosporins, the first generation and the second generation, do have a pretty good incidence of cross-reactivity in the 1 to 5% range. The third generation and fourth generation cephalosporins, not so much. And you'll be studying those later. Imipenem, which is a carbapenem, and penicillin in the beginning were believed to be cross-reactive half the time. And that was a bad study, and it was proved later that it's really only about 1% cross-reactivity. So that means, I say I'm allergic to penicillin, my chance of having a reaction to imipenem is 1 in 100 if I had a true reaction to the imipenem. Azatrianab is an alternative. Unfortunately, it's only primarily an anti-pseudomonal drug. It's not a bicyclic beta-lactam, so it's a little different in its chemical structure. And there is no cross-reaction with penicillin. That's definitely been shown. So the last sentence is the important one. Determine the nature of the penicillin allergy before giving the other beta-lactams or cephalosporins. And if it's anaphylaxis, angioedema, or bronchospasm, do not give the drug. That's the rule. And delve into the nature of it. If somebody says they're allergic to penicillin, delve into it in terms of when did it happen, what was the exact reaction, and so on, to determine how clinically significant that reaction really was. Okay, here's your first little, yes?
So, like you just said earlier, like, what if the patient doesn't know what kind of reaction he had?
Mm-hmm.
So let's say he had a serious reaction in childhood, but he doesn't remember.
Mm-hmm.
Would you take the chance, or?
There are some things you can do, and they're called diagnostic tests, to determine if you really need to use the drug and there are no other alternatives, then you can do some tests. I'll talk about it in a minute. That doesn't happen very often, and generally, if that were the situation, I would never give the drug in a clinic setting to somebody who you're not sure. You would do it in a hospital setting where you have the emergency drugs to treat it. And we'll talk about those treatments later. Okay, here's your question. What percentage of patients who state they are allergic to penicillin are likely to have a reaction to penicillin? Google that. See what you find. I did. Give you a couple minutes. Anybody who finds the answer, let me know. There have been a lot of studies on this, and a lot of different study protocols. So, as you might well imagine, depending on how you do the study, will determine. Anybody got an answer? What do you got? How much?
10%.
Right in the middle. It's 5 to 20%, and it depends on the source and the design of the study. Some of the studies that were well designed actually did skin testing to determine if the person truly was allergic. Some of the others just took their word. But probably the number is closer to 5 to 10%, somewhere in there. So when you get out in your clinical practice and somebody says, I'm allergic to penicillin, when did it happen? Was it oral? Was it IV? What were you treating? What was the reaction? If it was a rash, I don't worry about rash. I see it in the hospital setting every day when I'm doing pre-op orders for patients who are going to surgery. And they say they're allergic to penicillin, and the doctor orders a cephalosporin, which is very common as a pre-op surgery prophylaxis. If it says penicillin rash, I take that into account, realizing that the cross-reactivity is probably close to 1 to 5%. And rash is not that serious. Now, if it said anaphylaxis, then I'd be worried. I'd be calling the doctor. All right. Here were the sources I used. I just Googled what percentage of patients who claim to be allergic to penicillin are really allergic. And these are the two references I got. One was Medscape, which was really good. And there was an internal medicine article called This Patient Allergic to Penicillin? ? Quite good. All right, here's the first learning point. Pay attention. Name 2 patient-related risk factors. Notice I stressed patient. For drug-induced skin eruptions. That would be Kevin. Is Kevin here? Where are you, Kevin? Raise your hand. Oh, yeah. You can go back on the slides if you want. So this is patient-related risk factors. Yeah, that would be the 2 top ones I would have. What else? Look up here. HIV and other viral infections, autoimmune diseases would be in that. Previous reaction. Their phenotype, which we'll discuss in more detail at the end of the lecture. And then a history of multiple reactions. All right, Kevin, you got the top 2. Keep going. Learning point 2. Which drug category has the highest incidence of skin reactions? Drug category. Gia. Gia here? No? All right. Why don't I pick Helen? Brain? Is it Brain? Helen? She here? Wow, we're striking out on 2. How about Joseph?
Right here.
Ah, I knew you were here. I recognized the picture. Yeah, go ahead.
Infection treating agents.
Yeah, anti-infectives, right, or antibiotics. Name 2 common drug classes within this category.
Penicillin and cephalosporin.
Very good. All right, and sulfonamides. There are a lot of other antibiotics. I should have started this all by saying every single drug on the market has the potential to cause a drug skin reaction. We're talking about the ones that are more common. But every single drug has a potential. I had a lecture in pharmacy school from a dermatologist and an allergist. He had a patient who was allergic to water. No lie, he was allergic to water. They had to redistill the water 1,000 times until he didn't get a reaction. There was something in the water, obviously. You're not allergic to H2O or you'd be dead if you truly were allergic just to water. Yeah, he was allergic to water. My granddaughter has a friend in college that is on the rowing team at Gonzaga, and he would break out in hives when he got out in the cold. He was allergic to cold. All right, just to remind you, cross-section of the skin. Why is the skin such a target for drug reactions? 1, it's the largest organ. It has a big, huge blood supply. It acts as a barrier, right? Think of the skin's function. It's a barrier. And that barrier has built-in immune factors, so there are immune factors in the skin. It has a lot of mast cells and basophils, which when you degranulate mast cells, what do you get? You just said it, histamine, right? You not only get histamine, you get bradykinin, prostaglandins, and all kinds of inflammatory mediators are released from these cells. Oh, I forgot to give you my little pearl of wisdom. When you're making a clinical diagnostic differentiation between a drug and not a drug as the cause of the skin reaction, remember this. This sounds really silly, but it was told to me by a medical director in ICU, and it really has stuck with me. The most common things happen most commonly. Now that sounds stupid. If you hear horse, or you hear, I give it away, if you hear the sound of hoofs on the ground, it's probably not a zebra. It's most likely what? A horse, right? So the most common things happen most commonly. So if somebody's on penicillin and they get a rash, it's probably the penicillin, right? Because that is a common known thing. If you have a cough, what do you think you most likely have? What is the most common thing that causes a cough? A cold. All right. So that's my little pearl of wisdom for the day here. Let's see. I wanted to tell you one other thing about skin. Oh, the high density, the barrier function. Also, the skin, believe it or not, has metabolizing enzymes in it. There's the hepatic metabolizing enzymes, which have you studied that yet? Drug metabolism? And okay. There are metabolizing enzymes in the skin. So all of those factors put together make the skin a prime target for drug reactions. And there are three basic mechanisms which drugs can cause a skin reaction. Direct toxic effects, like I mentioned with the chemo drugs, and there are others besides chemo drugs. There is a non-immune, or what we might call pseudo-allergy. And what do you suppose that's due to? It's degranulation of the mast cells. Or things like bradykinin, those inflammatory mediators, those cause pseudo-allergy. They're not related to the immune response that you see here, where these are hives and urticaria, or urticaria, same thing. The immune response is mediated by what? Antibodies, right? And sensitized T cells. We'll talk about that more. Okay, so those are the three basic mechanisms that drugs and how they can affect the skin. Now we're going to talk about a bunch of examples. Before we get into the examples, the morphology, you need to understand the morphology. This helps you determine whether it's a drug reaction or not. Flat, distinct, discolored skin is called macule. It can be varied in size and shape. It comes in all shapes and sizes. If it's elevated, it's called a papule if it's less than 1/4 of an inch. It's a plaque if it's greater than that. And if it's really raised up, like this one over here to the right, that's a nodule. So here's a papule, right, these little ones here, and here's a plaque, and here's a nodule. And then also you can get something that looks like acne. If it's fluid-filled, or it's a blister, you call it a vesicle. And these are little vesicles. Those are usually less than 1/2 an inch. Bulli are greater than 1/2 an inch, and they look something like this, and they can get even bigger than this. In fact, they can get gigantic. Now, small raised bumps. This actually is one of the more common skin reactions to drugs. It's called morbilliform or measles-like. It's pretty faint, but you probably have never experienced measles, right? Anybody here seen anybody with measles? Of course not, because we vaccinated them. Unless you were at Disneyland last year, you might have seen it. But the reaction looks like this. Just these little bumps all over the trunk, generally all over the body. And then there's the typical skin allergic response, which you saw on the very first slide, the lead into the PowerPoint, where if you take your finger and you scratch really hard, it turns white and then later turns red on the edges. That's called a wheal reaction. That's an inflammatory reaction. That's this, which we call urticaria or hives. Very common. This and morbilliform are the two most common skin reactions you'll see. Now, as far as where it is on the body, this distribution and the color of it will also give you a clue. It can be localized, one place on the body, on one side. It can be systemic, meaning it can be all over the body, or it can even affect other organs besides the skin. It can be just on the trunk, it can be just on the extremities, it can be one side or both, it can be intertriginous, which is in body folds like here, or it can be fixed. Same location, but localized, like this one up here on the right. That's a fixed eruption. There used to be a OTC product called X-Lax. I think it's still out there. Used to contain the dye phenolphthalein, which was a bowel irritant. That caused so many fixed reactions, drug reactions, they took it up. That ingredient was taken out of X-Lax. Now it's Bisacool is the ingredient, which is still a stimulant laxative. These are some bullseye reactions to drugs. This one's from sulfa here. This is a photosensitivity reaction, which we're going to discuss in a minute. And this is skin pigmentation. And this is the nasty necrosis that we're going to talk about later. The color of the skin reactions, usually they're red or pink, but they can be purple, they can be brown, they can be blue, they can be gray, they can be all kinds of colors. So I'm going to go over some terms real quickly. Erythema. Redness simply means redness of the skin. Purpura is these little purple spots. Usually you see this with a decrease in blood platelet count, but it also can be caused by drugs. Ecchymosis is a technical term for bruise, bleeding underneath the skin. Maculopapular, you're going to hear this term all the time. Maculopapular is those flat, irregular, varied size redness, and interspersed in there are small confluent bumps. So those are papules. So you got papules in among the macules, so it's a maculopapular reaction. Very common to drugs. Urticaria, we just talked about, rash. They don't always have to be round. They can look like this. Dermatitis just means inflammation of the skin. If it's contact, obviously the skin comes in contact with an allergen or a chemical. Atopic is eczema, where there's an inflammatory condition of the skin. And then exfoliative is where the skin just sloughs off, like this. You get this in psoriasis. Here's a key slide. Realize when you see a patient coming into the pharmacy and they say, I got this rash on my arm, this will help you determine if it was drug-related or not. You may not ask them all these questions, but the key thing is that when did it start? Did you start any new drugs recently? So first, though, if you really wanted to do a detailed differential diagnosis, you'd ask family history. Is there autoimmune history, autoimmune disease history? Is there allergy history? Past medical history, do you have asthma? Nasal polyps, by the way, and you might get this in one of your major cases. Nasal polyps are associated, along with asthma, that triad and hay fever are associated with aspirin and allergy. Anybody who has that triad, asthma, nasal polyps, and hay fever, will be very susceptible to aspirin hypersensitivity. Latex allergy, recent viral infections or bacterial infections. But here's the key thing. Ask, when did it happen? Did you have other symptoms with it? Fever, tiredness, itching. Did you ever have a previous exposure and a reaction to the drug that they may have started, if they did start a drug? And then these two things are key. Where is it on the body? And what does it look like? We just went through that in the previous 2 slides. And then get a detailed medication history, all the drugs in the last 3 months. If a drug reaction in the skin is going to occur, it usually happens within the first 3 months. Actually, within the first few days for most drugs. There are some exceptions to that. But there are also exceptions where it can be even, and on rarely, more than 3 months after starting a drug. But for most drugs, as you see when we go through the examples of when the onset is, it's usually within either hours or days. Get a patient drug allergy history, and if possible, a genetic profile. And we'll talk about the Asian ancestry and how it affects drug skin reactions. And then the question that was asked earlier, how do you determine if somebody is truly allergic? You can do diagnostic tests. There's a skin testing, and there's actually a skin test for, and this skin testing is only used for IgE-mediated type 1, that's the immediate type of reactions, and usually with the beta-lactam antibiotics. In general, skin testing with other drugs is not very useful. Most allergists will tell you that. But there is what's called a pre-pen or a penicillin kind of derivative complex that is used for skin testing. Unfortunately, as you see in red, it misses 10%. So if you get a negative, you're not sure. You have a 1 in 10 chance of the patient still being allergic to penicillin. So if it is positive, however, that's a pretty good sign. 98% of the time, the person is truly allergic to penicillin. So positive is good, but it can still miss. If it's negative, it can still miss 10%. And this is, like, again, this is used for the serious situation where you have a patient who you have no other alternative and they need to get the drug, and they had a past reaction with anaphylaxis, angioedema, bronchospasm, the serious types of reactions. You want to rule out. Unfortunately, it's not advised to give a skin reaction to a drug in which you've had those serious reactions. You could do it and take a risk, but it's a big risk, and it shouldn't be done outside of a hospital setting. Now, the graded challenge is a little different. Say you're given an antibiotic, it's an oral capsule, let's say Keflex. A couple weeks later, you get a skin rash. Now, a year later, you need another cephalosporin oral. Fortunately, there are a lot of alternatives, but let's say there are no alternatives, and you have to take this Keflex again. You can do what's called a graded challenge, where you get Keflex liquid, diluted, and give small doses. You know, the usual dose of Keflex is 250 to 500 milligrams. You give 2 milligrams. Wait a while. See if anything happens. It could be hours, it could be a day. Then give double that. Then give 10 milligrams. Then give 50 milligrams, and see if this rash reoccurs. You don't give the full dose. So that's called a graded challenge. You'd never do it again if the person gave you a history of the anaphylaxis type reaction, the serious reaction. It does not modify, this graded challenge doesn't modify the immunologic response. It just tells you if it's there. And you're playing safe by giving smaller doses orally. Now, the last thing is called desensitization. And if you work long enough in a hospital, you'll get one of these. The most common desensitization protocols, and there are many of them, and you can Google them all, and allergists will use them, are for carboplatin and cisplatin, 2 chemodrugs. The reason that you need to desensitize the patient to these drugs is they need the drug over and over. It's essential they get the drug. Like ovarian cancer, what happens is it's very responsive to carboplatin, but it comes back. So generally with ovarian cancer, you have to give the carboplatin over and over and over again over a period of years. And after a few courses of carboplatin, a hypersensitivity, serious hypersensitivity reaction occurs. So rather than not give the carboplatin, what you do is you dilute the carboplatin, and you start off with a very dilute solution, 1/1000th of the normal, or 1/100th of the normal concentration. And you double that concentration, and you give this intravenously every 15 to 20 minutes until you reach the full therapeutic dose For carboplatin, it could be 350, 500 milligrams. So initially you might give less than a milligram. And then you double that in 20 minutes to 2 milligrams and so on until you've given the full dose. And this is done quite commonly, particularly in oncology centers. Now, realize this is only temporary. You have to do this every single time you give the drug. Because it does not impart immunity to the drug permanently, only during the time you give it. Why it works, I'm not really sure. Maybe you're just nudging the immune system, but you're able to give the full dose with no reaction. It can be done with penicillin, and it's done in situations where penicillin is needed as the only drug that can be used, like subacute bacterial endocarditis from certain bacteria, and you have to give the drug penicillin for a long time, or quite often over and over again. Then you can desensitize the same way. Start with very low doses and then keep doubling it. And the immunity only lasts as long as that drug's being given. One more slide, then we're going to take a 5-minute break. So, how do you treat these mild, moderate reactions, these skin reactions? You already talked about this, right? Did you have like 3 lectures on OTC, dermatologic disorders? So most of the care, obviously, you stop the drug. That's the first thing. If you realize and identify that the drug is the cause. There are a lot of H1 blockers, the antihistamines like over-the-counter Benadryl. You wouldn't generally give oral corticosteroids like prednisone unless it was more severe reaction. Generally, you would start with topical corticosteroid like hydrocortisone. Pain management would generally be mild, so you give acetaminophen or recommend ibuprofen or one of the NSAIDs. And then the topical treatments, the old calamine lotion. You ever hear of calamine lotion? Yeah, for poison oak. It's actually a drying agent. It's a clay. The one that really worked, because you get oozing with poison oak, that's why you put calamine on it as a drying agent. But you also, in some that don't have oozing or blistering, you'd use a wetting agent. You know what the best non-pharmacologic treatment of itching is? An ice pack. Simple, easy, and it works. Try it. Calamine lotion, phenolated. I don't think it's still sold over the counter, but we used to add 2% phenol to the calamine just by adding phenol crystals and shaking it up. That really worked to control the itch. Phenolated calamine, if you can still find it, it's sold over the counter. It might be. The other key thing is when somebody has a reaction, record it in their drug history on an electronic record. Or if it's a paper record, it's a paper record. And if other things other than just a simple rash, like blisters, pain, pus, rash all over the body, or the drug is definitely needed, and other areas are involved, or you have arthralgias, myalgias, fever, and that kind of thing, refer them to a dermatologist or an allergist. And then have you learned about MedWatch? MedWatch is the FDA's drug reaction reporting system. If it's a well-documented drug reaction, report it. The FDA does a pretty good job of cataloging all this. All right, we're going to take a 5-minute break. Well, we're going to take a 10-minute break. Come back at 20 after. You guys probably taking your bathroom break by now. The way it works is, let's say it's carboplatin.
So it takes a whole day to finish one dose.
So I could take a few, not a whole day. Because you're upping the dose. So let's say it starts 1 milligram. And you go 2 milligrams, 4 milligrams.
And let's say this guy needed it for a whole life. So we were doing this every day?
No. Most oncology drugs are just given. There's a few, like 5FU, that are given over 7 days.
Okay.
But in the case of carboplatin, it's just You're giving it 1 day over a few hours. So it's going to take a little longer because you're doubling the dose, right? And then you have to tally up the dose, and when you hit 400 milligrams, you stop.
But like it's only for one time a day. I can only
Yeah, you have an IV, and the patient's on it, and then you give the 1 milligram dose, wait 15 minutes, and it's diluted in a solution. And IV solution.
like I guess that works. And then like let's say the drug was a series, and then you need to give it for 4 days.
Oh, you'd have to do it every day. Oh yeah. Did I put a word on there? I think I did.
I know, not this stuff. I had to.
Yeah, this one I left it off. There should be a. There should have been a longer answer. Yeah, you need to know this for the future. If you're ever going to go and keep that. No, just what they're used to. We're going to do a study group discussion with that topic.
I thought I read like it was like a mild, like you would, so like a full on sleep, like.
I'll give you an example. Okay? Yeah, I'll give you an example. It's a good, and it's going to be a good study.
During last walk, I was feeling good about going.
we're gonna get started. We have still a little bit of stuff to cover. One of your classmates come in and asked about the little learn box, and I noticed that I left it off of the diagnostic tests. So I've added it now. So add the learn box to the diagnostic test. Now, the other question was, the best way to study is to make up questions, particularly multiple choice questions, in each of these slides. If I was looking at this slide and I'm the instructor and I'm going to make up a question, what would I do? Let's see. If it was multiple choice, I'd say all of the following are important for the assessment of the differential diagnosis of a drug-skin reaction, except. And then I would go through and list ones that are time of onset, the distribution, the morphology. And then I'd say something like, get a detailed medication history of all the drugs that were started in the last 12 months. What does this say? 3 months. So that would be the wrong answer. In doing that with each of these slides, what you're doing is you're thinking of wrong answers. Anytime you create a multiple choice question, you've got to come up with 4 wrong answers, right? Or 1 if it's the accept type. And in doing that, that's a good way to learn. I used to do that. I had did I tell you the story about Brockman Hansen? He was our pharmaceutical chemistry professor, his first year of teaching at UC San Francisco. At the end of the first semester, he says, any of you who would be willing to submit test questions for the upcoming test, I'll entertain them as possible test questions. I wrote an entire exam. Like 20 multiple choice, some fill-ins, some true false. Used my entire test. Needless to say, I was done in 15 minutes. And the rest of the class thought I gave up because I turned in my blue book, and in 15 minutes I was done. And everybody looked at me like, where's he going? He must have given up on it. I knew every answer except, he did throw in one of his own. What are the ingredients? I'll never forget. What are the ingredients? Because I got a 98%. I didn't get a 100%. What are the ingredients in a suppository? And I left out water. So I got 98%. What are you going to do? Okay. So I've added the learn box to the diagnostic test if you want to think that could possibly be an exam question. So if I was making up a question about this, I would say maybe, and we'll have it in the study group discussion. You'll happen to notice that one of the study groups has this. What's the difference between desensitization and graded challenge? What's the difference? What does the skin test tell you? If somebody says, I had a negative penicillin skin test, does that mean they are not going to be allergic to penicillin? Of course not. There's a 10% chance that this skin test will miss that allergy. Okay, so moving along. Guess what? It's time for you to participate. Learning point. This is a big lesion. This is the man's arm. And this is his trunk or chest. And this is what? That would be the left side, right? 47-year-old male, otherwise healthy, takes ibuprofen for a toothache for 2 weeks. 4 weeks later, he presents with a skin eruption and pain. Describe the morphology and distribution. Carolyn. Carolyn here?
Yeah, right here.
Okay. Go ahead, Carolyn. How would you describe the morphology? What does it look like? Remember that little chart we had on the slide? It's obviously a blister, right?
Yeah.
What's the technical term?
Fluid-filled blister.
Yeah.
Bleeding pustule, pustule.
So where is it on the body?
On the trunk.
Trunk, yes. Is it on both sides?
No.
No. There's not. This is the only lesion he had. So it's a large bullseye or blister. It's filled with fluid. It's localized to that one area. It's on one side on the trunk. So that helps you with this history. You can pretty much be sure it's ivy growth that caused it. unless there were some other extenuating circumstances, but it was the IV protocol. Okay, learning point 2. Patient develops a rash 2 days after taking Augmentin for cellulitis of the foot. Ugly looking little rash on the chest. So Tran, yes. How would you classify the morphology? What does that look like? Well, it's systemic in the sense that it is covering his upper extremities and chest. I bet you it's not on his face though. We'll talk about it in a minute. Well, how would you describe this type of rash? Is it a fixed eruption? Is it a... No? Meso-like would be small little pinpoint. Meso-like is very descriptive. It's just little tiny little red dots all over. What did I say was the most common one we could see? Maculopapular. Okay. All right, now we get into the meat of it. These are the examples. These are the ones you want to carry around with you on your rotations after printing this out. So we're going to start with the non-immune, or pseudo-allergy is another term you can use. These are reactions that occur without activating any antibodies or any T cells. It's not an immune response. It's usually related to degranulation of mast cells and basophils, releasing all these inflammatory mediators we were talking about, histamine, leukotrienes, prostaglandins, and kinins, just because of the chemistry and pharmacology of the drug. And then there's the drug toxicity, which was that second mechanism that's a non-immune reaction. It's just because of the dose and the toxicity of the drug itself. So we're going to start with photosensitivity. This is something you always have to counsel patients on with certain drugs, and we're going to talk about those drugs. The first is the non-immune phototoxicity. Photosensitivity, there are two kinds, photoallergy and phototoxicity. This is phototoxicity, which is non-immune. We'll talk about photoallergy in a minute. It's a drug or chemical that reacts with sunlight to cause inflammatory skin condition or reaction. It's drug dose and UV dose dependent, meaning the larger the dose and the more sun you get, the more likely it's going to happen. You get erythema and edema. Basically, it's a sunburn, like you see here on this woman's chest. In severe cases, and if you stay out in the sun long enough, it can cause vesicles, bullae, and it becomes very itchy. But generally, it's more like this, like an exaggerated sunburn. Here's the key. It can occur within minutes of exposure to the sun. So if you're on one of the drugs that can cause this, you go out in the sun for 3 minutes, and this reaction can occur. And it starts becoming evident within minutes to hours after the sun exposure. It may not be necessary to stop taking the drug. And the area that it's confined to is only where UV light touches the skin. So if you're wearing skin protection, and we'll talk about other things in a minute, or sunscreen, the reaction can be avoided. And it can occur with either systemic, like oral drugs, or topical drugs. Some of the culprits, if I was to make a slide out of this, what would I do? I'd say, what are the most common causes of phototoxicity? What drugs cause phototoxicity except? And then make a multiple choice question. And in writing down those correct answers and the one wrong answer, it helps you remember it. Antifungals are big for phototoxicity. The biggest ones are the tetracyclines like doxycycline, minocycline. Amiodarone is a big one. We're going to talk about that in much more detail later. Diuretics, NSAIDs, phenothiazines, which aren't used in psychiatry as much as they used to be, but there's still a few ones floating around. And then the topicals like the retinoids used for acne, and then there's 5-fluorouracil cream that's used for keratosis on the skin. So those are the common culprits. There are a lot of other agents that cause phototoxicity, and here's a reference where you can go read those, but less commonly than these drugs. These are the major culprits. Now, we're going to switch gears from the non-immune to the immune for a minute and then get back to non-immune, but because it comes under photosensitivity, here's photoallergy. This is an immune response. It is mediated by type 4 cell-mediated immune response. So it's sensitized T cells. It differs from phototoxicity in that it doesn't take much of the drug to do it. Less drug is required. Also, there's a much lower incidence of this, fortunately, because it's much more severe. Look at that. That's terrible. Look at this. This is more like a dermatitis. It's less like a sunburn, more like a dermatitis. So it's usually more severe, and its onset is delayed. It's not occurring with 3 minutes of exposure to the sun and then appears within 20 minutes on your skin, turns red. This one is delayed a day or 2 or 3 before this reaction occurs. And here's another key difference between this and phototoxicity. More than one exposure is required. So what that means is you take the drug, go in the sun, nothing happens. A year later, you take the same drug, go in the sun, the reaction occurs because you built up an immune response. Affects the sun-exposed areas, but it may spread to areas that were not exposed to the sun. That's how it differs from phototoxicity. And it's usually a lot itchier than phototoxicity. And this one, it differs from phototoxicity. You've got to avoid the drug or chemical in the future. Whereas phototoxicity, you can take the drug as long as you protect yourself from UV light. Okay, what are the main culprits here? Basically, some of the same ones that you saw for phototoxicity, but here's an ironic one, sunscreens. The wearing agent you would use to protect yourself used to contain para-aminobenzoic acid, PABA. This drug was banned from all sunscreens about 10, 15 years ago because it was causing photoallergy reactions. Read the ingredients in your sunscreens and you'll see that some of them contain benzophenones. Particularly this one is particularly problematic in children, oxybenzone. So don't give this to kids, this sunscreen to kids. I don't think it's in most of the pediatric ones. You'll see there's so many sunscreens on the market. But read the ingredients. The salicylates, too, have been implicated. And then again, the NSAIDs, the topical 5-FU, the antifungals, but here's one unique, Dapso, the only drug that's not on the other list. And fragrances like musk have been known to cause photoallergy reactions, and the phenothiazines. So you see there's some commonality between the drugs that cause phototoxicity and cause photoallergy. Here's what you tell the patient. Avoid the sunlight if you can. Always wear sunscreen with UVA protection at 30 or better. Wear protective clothing. And there's if the patient's going to be on the drug quite a while, these are some more effective forms of ultraviolet protection. You've got to protect the eyes as well. Sunglasses, head covers, and severe, like if you drive a lot, you're a UPS driver, you might want to cover your arms as well. Turns out that baseball caps only have an SPF of 3. I don't know who figured that out, but somebody did. So it's not a really effective way of protecting your face of UV light. It might be. The difference between 15 and 30 is pretty small. I used to have the slide with it greater than 15. I would say 15 would work as well, personally. I think it probably gives you enough sun protection. As long as it's got both A and B. Great story. My first professor in pharmacy school was a Dr. Kumler. Dr. Kumler met us at The lecture was supposed to start at 8:10. He started at 8 o'clock. But we're all these nervous first-year students, right? We're all standing outside the room. He shows up at 8. You go in Cole Hall there at UC San Francisco. He walks up to the board, grabs the chalk before computers. Organic chemistry. He starts writing. And as he's writing, he's taking his eraser and doing this. So fortunately, he lectured right out of the organic chemistry book. So we just took our highlighter and just highlighted the sentences in there. We got a pop quiz every Friday. Every single Friday. There was a quiz. He is the inventor of the sunscreen index. That's why I mentioned it. He took a radio, as his doctorate degree, he took a radio, modified the radio somehow, took chemicals, put them in solution, and came up with the 1 to 10 scale at that time of sunscreen index. So something with a 1, very weak, something with a 10 had maximum sunscreen protection. This was back in the 50s, so it wasn't too sophisticated. That's about the time that, you ever heard of the brand Sea and Ski? It was a brand of sunscreen that was popular back in the 50s and 60s. It's called Sea and Ski. Yeah, Sea and Ski. So, in other words, if you're at the ocean or you're skiing, this is a good thing to wear to protect you from ultraviolet light. He sold the rights to that sunscreen index to Sea and Ski for, well, he became a millionaire eventually with all the patent rights. So he developed the very first sunscreen index. Now it's a much more elaborate sunscreen index and goes all the way up to 50. There really is no advantage of using anything greater than 30. Really, clinically, it doesn't really matter. So 15 to 30. All right. So you can use topical steroids for the reaction emollients and wet compresses. This is stuff you probably already studied. All right. Let's talk about colored skin, hyperpigmentation of the skin. This is where the drug deposits in the skin and changes color with absorption of ultraviolet light. Now I show you some teeth, only to make you aware of this major side effect from tetracyclines. Doxycycline, minocycline. Tetracycline is as a tetracycline. Tetracycline is not prescribed anymore because it's not available in the United States. But if you give it to a child under 9 years of age, there is permanent staining of the teeth. Permanent staining of the teeth. And it's their permanent teeth that come out. It stains the teeth that are underneath the baby teeth. I just bring that up as a sidelight. I want you to know that. So if you ever see a tetracycline derivative prescribed to a child under 9, call the doctor. Most pediatricians are aware of this. Here's an example of chloasma, melasma, which is a browning of the skin. You get these skin spots like this, skin spots from anticonvulsant phenytoin. Here are the drugs that induce hyperpigmentation of the skin. Amiodarone, which we'll talk about, makes the skin blue-gray, and we're going to have a whole slide on that one. Antimalarials, here's hydroxychloroquine, used for malaria. Makes these kind of blue-black patches on the trunk. And then I already mentioned phenytoin causes the chloasma brown. It's about a 10% incidence, so about 1 in 10 patients on phenytoin. Anti-infectives, particularly minocycline. That's the tetracycline that will cause a kind of a blackish, grayish discoloration of the skin. Some chemotherapy agents, and you've heard of Latisse, which is being used to make your eyelashes grow. Lumigan and Zalatan are used for glaucoma. They cause a pigmentation of the iris. Oral contraceptives can cause brown patches on the face. Okay, that's pigmentation. Now here's amiodarone. The reason I single this out is because it's very common. And it's due not only to the actual drug, but to its metabolite as well. It causes a slate gray, or as they call it, the Smurf face. Due to the deposition of melanin and lipofuscin in sun-exposed areas. in sun-exposed areas. The incidence is widely variable, and I think it has to do with how the reporting systems were done, but it does, you're at risk at higher dosages, of cumulative doses of 40 grams or more, of developing this blue-gray. It could be mild like this, or it could be even more severe like this. There's even a keratopathy where you get these, in the iris, you get this like halo around the iris in the sclera. It does, and that happens in everybody on amiodarone, but fortunately it doesn't affect their eyesight or anything, but the few patients might complain of halos or blurred vision. So what do you tell the patient if this happens? They start an amiodarone, they come back in a month or two and they say, hey, my skin's all blue. What's going on? Well, you might either stop the drug entirely and switch to something else, but if consulting with a physician, you may be lowering the dose. But you could avoid sunlight, wear sunscreen, and protective clothing. That will help with preventing it. The problem is, once that pigmentation occurs, it takes months, literally months, to go away. So tell the patient, don't expect it to go away right away. And you know the reason why? You haven't studied cardiac drugs yet, right? Amiodarone's half-life is 2 months. 2 months average. So when you start taking amiodarone, to reach the plateau level is 4 to 5 half-lives. That's almost a year. So it's in the body. If it was going to be eliminated, it's going to take 8 to 10 months before it's completely gone. You'll study that later. And it has a metabolite with a much shorter half-life that's also cardioactive. Okay, learning point. You ready? 19-year-old female with acne is prescribed doxycycline, clindamycin topical. She takes a short 3-minute walk on a sunny day to get her mail, and after 20 minutes her arms and face are sunburned. Which drug most likely is responsible? Is this an immune response? Scott. Scott here? Hi, Scott. You can go back and look. What's the most likely drug? Is it the clindamycin or the doxycycline?
Doxycycline.
Yes, correct. What about, is this an immune response? No, it's not. It's a phototoxicity. Tetracyclines interact with the UV light to give you this mild sunburn. Okay, learning point 2. Avid golfer, cardiac disease, prescribed a drug for his arrhythmia. After 4 months of therapy, complains of grayish-blue skin on his face and arms. What drug is most likely? Is it a non-immune reaction? And what area of the body is affected? Giovanna? Yes, Giovanna. What's the likely drug? Amiodarone, right? Is it immune or non-immune? Yep, it's non-immune. What areas of the body are affected? Any area exposed to the sun. In this case, if he's a golfer, he may have been wearing short sleeves. We don't see his arms, but he would have it on his arms if he was wearing short sleeves all the time. All right, here's a common one. Seen a lot in the emergency room and in a lot of hospitals. Vancomycin red man syndrome. Have you learned this one yet? Oh, you did? Oh, good. It is related to a rapid IV administration of the vancomycin. And it's called, the reason for the reaction is a degranulation of the mast cells and basophils. Its distribution is like this: the face, the torso, and the arms. It is extremely uncomfortable. The patients don't like it and never want it to happen again. It doesn't look that bad, but it's very uncomfortable. The treatment is either H1 or H2 blockers, as you might expect, since you're getting a release of histamine, right? The prevention, and this is how you prevent it: for every 500 milligrams of vancomycin, run it at least 30 minutes. So if the dose is 1 gram or 1,000 milligrams, how many minutes? Huh?
I have a question.
Yes.
If the patient case scenario is going to be posted on the
Is what?
The patient case scenario is going to be posted on
Oh, you know what? This one isn't on your, did I put this on that? Oh, the questions? No, I can if you want. You want me to post? I can post it later. Yeah, sure. I'll do that later.
Quick question.
Yes.
If this is known to happen,
Mm-hmm.
how come the slow infusion isn't always done? Like,
It is.
oh, it is.
Yes, except when the nurse makes a mistake. It just happened the other day in our ED. In fact, it happened in one young, small female who was given a fairly large dose of vancomycin, and they ran it at the proper rate, but she still got the reaction. But that's pretty rare. If you follow this rule, you generally will not see red man syndrome. Doses can go as high as 2.5 grams, 2,500 milligrams. That's a loading dose. But the usual maximum dose is 2,000 milligrams, IV, as a single dose. The average dose is somewhere around a gram, gram and a half. Now, if I said 1,800 milligrams, and that dose is commonly prescribed, how fast would you give it? Very good. Always play safe. Go up in the time you are going to give it. It's 1,800 milligrams is closer to 2,000 milligrams. 2,000 milligrams would be 2 hours, right? 4 times 30. Mississippi mud, the reason I put that on there, that's a beer in Louisiana that you can buy. It looks like mud. It's a pretty dark beer. The early experiments with vancomycin back in the 60s, the impure vancomycin in the vial looked just like the Mississippi mud. So that's how it kind of got the nickname Mississippi vancomycin, impure vancomycin Mississippi mud. Here's one recent. Notice there's no learn box here. This is a recent new black box warning on an anticonvulsant for partial onset seizures called Protiga. It has 2 generic names, depending on whether you're in Canada or Europe and the United States. It causes blue skin. Look at that. On the feet, the nails, the lips. It also will discolor the retina. And there have been some visual problems with it. There are only maybe 3,000 patients on it as of 2013. I don't know how many there are now. I tried to find out, but I couldn't find any more recent information. And it reverses itself within a few months. And the reason I put Blue Man Group, because it's a blue discoloration. Anybody go see the Blue Man Group?
I've seen them.
You ever seen it? Where's it, Vegas?
No, New York.
Oh, New York. They're fun. That's a fun group. Okay, here's one. Warfarin-induced necrosis. Getting away from pigmentation for the moment. Very rare reaction. Occurs mostly in women, and in less than 0.3% of the population is at risk because it's due to a plasma protein C or S deficiency. Have you studied anticoagulation yet?
No.
No. When you do, you're going to learn about these vitamin K dependent. This is some of the vitamin K dependent clotting factors besides 2, 7, 9, and 10. Plasma proteins C or S deficiency. The onset is 3 to 10 days, and it's pretty gruesome. It starts with the little petechiae, the little blood blisters, then turns into purpura, which is a large bruise. Then they get blood-filled bullae. This is a woman's breast here. And notice it attacks the subcutaneous fat is where it distributes mostly. This is where you get the treatment of this. Of course, stop the warfarin and reverse it with vitamin K. And then you got to worry about infection. You got to do surgical interventions. And if you still need an anticoagulant, there's lots of other choices which you'll learn later. But here's the key I want you to remember for this. Never, ever start anybody on warfarin above 7.5 milligrams as the first dose. Ever, ever. It's totally unnecessary. Doesn't matter how much they weigh. It doesn't matter how old they are. Just never give 10 milligram 15 milligram I've seen loading, so-called loading doses of warfarin. You'll learn later that warfarin peak effect is 4 to 5 days out. The risk of warfarin-induced necrosis is much higher when you give doses greater than 7.5 milligrams. And it's totally unnecessary, and I still see it being done. But when you go to your AmCare sites in your 3rd and 4th year, talk about it. Now, patients can end up on more than 7.5 milligrams a day, but never start a new patient on warfarin who's never received it before, greater than 7.5 milligrams. The usual starting dose, and there are now metabolic phenotyping tests you can do to tell whether somebody rapidly metabolizes warfarin or not. But that isn't readily available yet. But we usually start, if I start a new patient, I start at 4 or 5 milligrams. That's it. I rarely will give 7.5. And I never give 10 milligrams as a first dose, ever. What happens is you give the first dose and you monitor the effect for the next 3 or 4 days of that very first dose. And how much it rises, and you'll learn this later, how much it rises will depend on what dose you give the 2nd, 3rd, and 4th day. There are guidelines and protocols. But just never give a loading dose greater than 7.5 milligrams. Here's an interesting little thing called purple toe syndrome. It's been associated with warfarin, but it's really not caused by warfarin, but it can be mistaken for warfarin necrosis. It's really due to cholesterol microembolism, usually people with cardiac disease. But sometimes, and because a lot of patients with cardiac disease are on warfarin, you see it. Yes?
So for the tissue necrosis, you said it is reversible with vitamin K. How does that happen? Is it just reversed from dying? Isn't it already, isn't your tissue already?
Well, it nullifies, it causes the liver is where the clotting factors are made. The vitamin K dependent clotting factors are made in the liver. And what happens is the vitamin K reinitiates the metabolism, blocks the warfarin effect, and reinitiates the synthesis of the clotting factors. So it nullifies the warfarin effect, but that takes days as well. All you're doing is halting any further damage. What damage is done is there. You're not, the only thing that's going to help that is treatment with surgery, debridement, antibiotics, and anything like that. Yeah, giving the vitamin K just is reversing the effects of the warfarin. But and again, that can take days. Okay, back to non-immune reaction. This one you'll see. I saw it in my son last year when he got mono. He didn't know he had mono. He had a sore throat, and they gave him amoxicillin for his sore throat. He got a rash from head to toe that looked just like this. It's morbilliform or measles-like rash. It occurs mostly in children because more children get mononucleosis. That's the Epstein-Barr virus, aka ABV virus infections. It's not an immune response. And this is the one example where nobody knows the reason why. The mechanism is unknown, but we know it's not a true allergy because it's not related to antibodies and it's not related to sensitized T cells. The incidence is up to 90%. 90%. In fact, you can almost use it as a diagnostic test for mononucleosis. Give somebody amoxicillin if you suspect it, and they'll get the rash. Crazy way to do it, but it could be done. It does not preclude giving amoxicillin or ampicillin after the mono is gone. So 2 years from now, somebody who got this rash could safely be given amoxicillin and ampicillin. It's more like a vasculitis in its mechanism completely unknown, but it doesn't mean you can't. So, see, this is where somebody would give label. I'm allergic to penicillin, I got amoxicillin, I got this rash. And it goes in the chart. Amoxicillin rash. The part that was left out was not an immune response. So you could give amoxicillin to this person in the future. It's usually pretty mild. So when amoxicillin is being prescribed, why is it being prescribed? I just told you. My son got a bad sore throat. This is somebody's throat. That's their tonsils right there with pus on them. They're infected. So one of the first symptoms of mono, besides getting tired and a fever, is a sore throat. And so they go to the doctor and they give you some penicillin to treat it, and most often it's amoxicillin or ampicillin. Contrast dyes. For those of you who do your acute rotations and spend any time looking at radiology and diagnostic tests, these are dyes that light up x-rays. They have iodine in them, which is a heavy molecule. These dyes cause a pseudoallergy. So as you might expect, they degranulate mast cells. The reactions occur in 5 to 8% of patients. Anybody had a radiology test with an IV contrast? Anybody? Yes? Did you get a warm feeling? Yeah. Did you get any itching? No. You had it extremely mild. But most patients will experience a warm feeling, sometimes a little itching. In the moderate situation where it's a little more severe, they might get vomiting, sometimes hives and swelling of the face. That's about 1%. The severe reaction is called the anaphylactoid reaction. Notice it's toid, meaning it's like anaphylaxis, bronchospasm, shortness of breath, respiratory distress, all similar to what you would see with anaphylaxis, but it's not immune caused, it's caused by histamines release. The ways to kind of prevent it, and patients will receive IV contrast more than once. It may be necessary to do the diagnostic test. So what radiologists will do is to prevent it, they'll use these are the newer class of iodinated contrast dyes, Visopaque and Omnipaque. They're called non-ionic. It's been shown that the ionic forms, the older forms of radiopaque dyes caused more reactions. So one way to kind of help prevent this, not to say that the non-ionic don't cause the reaction, but they do, but less so than the ionic. And if you use a lower iodine content, see this little number here? That's the amount of iodine. There's a 240 and a 370, 320, whatever it is. So using a lower amount of iodine sometimes will help. Giving it slower intravenously, just like with vancomycin. And pre-treating with an H1, H2 blocker and a steroid. Although I don't think the steroids help at all. Why would they? It's not an immune response. So the treatment after the response, if it's the more severe one, the only life-threatening situation is if it was severe anaphylactoid reaction, then you'd give epinephrine, which is similar to what you would do with anaphylaxis. It works in this case, and we're going to discuss an example where it doesn't always work. So it doesn't preclude the use of IV dyes in the future always. Sometimes it does.
Why did you use H2 blocker, not H1 blocker?
You're-
H2 isn't it in
Yeah, they feel that some of the reactions, some of the substances that are being released from the mast cells are related. So they recommend both. They'll give the cocktail is famotidine or cimetidine, that H2 blocker, and diphenhydramine, the H1 blocker, and a corticosteroid. You're right. I don't know why H2 would work that well. It's probably the most important drug would be the diphenhydramine, the H1 blocker. Here's a reaction to a chemo drug. Capecitabine, or Xeloda, is an oral drug used for colon cancer. It's a prodrug. The body converts this capecitabine to 5-FU in the body. The 5-FU leaks into the skin from the capillaries, and it causes this toxicity in the hands and the feet. It is dose limiting, and it occurs in 50% of patients after the 3rd month. And usually the onset is in the first 1 to 3 months of taking it. It's not taken every day. It's done just like most chemo in cycles. It's very painful. It's extremely discomfortable, if that's a word, uncomfortable. You have to hold the drug for a while and then restart it later. COX-2 inhibitors seem to help a little bit, one of the NSAIDs, and then steroids. It's very painful. Excuse me, very painful. Here's another group of cancer drugs. The epidermal growth factor receptor inhibitors. They cause a fairly mild reaction, but notice it's a papulopustular, meaning there's little papules and little pustules on the face, the neck, the chest, and the back, usually within 1 to 3 weeks. Here's another example where if you don't get this, the drug's probably not working to treat the cancer. Its risk factors are increased age and fair skin. Here's some of the nibs and nabs that have been implicated. And it's pretty easy to treat. Topical steroid, a little doxycycline. Here's one you're going to run across. Our faculty member, Dr. Baumgartner, is going to publish this article in Intensive Care Medicine this year, or maybe early next year. She helped me with this slide to bring it up to date. This is what it looks like. Swelling of the lips, swelling of the face with reddening, and in severe cases, swelling of the tongue, the inside of the mouth, and the pharynx. Now you can imagine that in this case, where there's swelling of the tongue, the soft palate, and the pharynx, what do you think happens to your ability to breathe? Yes, it's greatly compromised. It is caused by, and this is a pseudo-allergy. It's not immune response. We will talk about angioedema as an immune response later. It's caused entirely by ACE inhibitors. ACE inhibitors constitute 10 to 25% of all cases of angioedema. It's rarely life-threatening. This is the really extreme case. It affects anywhere from 1/10 to 0.7% of the population, and it is likely dose-related. In fact, patients who developed angioedema started back on a lower dose of the ACE inhibitor like lisinopril, and the reaction didn't reoccur. So it most likely is dose-related. The risk factors are female, over 65, smoker, and 5 times as greater in African Americans. Here's the classic example down here on the bottom right. Female, African American, over 65. Usually begins with days of starting therapy. It has been reported to occur later, but it's probably because if you're treating hypertension, which ACE inhibitors are used to treat, if the hypertension isn't under control, you ask the patient to increase the dose. It's most likely due to bradykinin. What happens is the angiotensin blocks the destruction of bradykinin. Bradykinin is a vasoactive drug. It will increase vascular permeability and vasodilatation, and that's what you're seeing here. So the treatment is to stop the ACE inhibitor, of course. Antihistamines, corticosteroids, and epinephrine are often used in the emergency part. Most of these people present to the emergency room. It's been standard of therapy for years to give these 3 drugs. The epinephrine is usually reserved when they have respiratory distress. In Dr. Baumgartner's article, which I've given you the reference here, when it comes out, you can read, these drugs are totally worthless. The epinephrine in particular. It does nothing for the respiratory distress. It doesn't improve the swelling. The only way to treat if somebody's having extreme difficulty breathing is to admit them into ICU and intubate them, put a tube in, and mechanically ventilate them with a breathing machine. The epinephrine has no effect at all. So that's not the life-saving drug. The life-saving is the mechanical ventilation. There's also a new drug out, icatibant. It's given intravenously. It is a selective bradykinin receptor antagonist. Great drug. $10,000 a dose. But it will reverse these symptoms within hours. So that's more proof that it's bradykinin that's the cause of this reaction. You can give fresh frozen plasma, which is kind of extreme. That's giving blood, because it contains bradykinin, which is what you're deficient in. The long-term therapy is, I would be leery of continuing the same ACE inhibitor even at a lower dose, but that might be a possibility. But the best thing to do is to switch to the other antihypertensive class, the angiotensin receptor blockers, COSAR. However, remember this, that still cross-reacts with the ACE inhibitors in about 5 to 10% of patients. So switching them to the ARB, they still could get angioedema in a small percentage. We'll go through these slides pretty quickly, but here's some things that are homologous to the skin. Your nails are part of your skin. Your hair is part of your skin, even though they're dead. They're part of your skin. And drugs affect these because you've got rapid division or rapid growth of hair with cell division. So as you'd expect, chemotherapeutic agents can cause nail disorders. So can the psoralins, the retinoids, tetracyclines, animalarials, zidovudine. And it takes months to resolve, as you would expect, once you destroy the cell division in the nail bed. It takes 6 months for the nail to replace itself. Hair disorders, alopecia. Alopecia is very common with drugs, as you know, with chemo agents. You lose your hair, not all of them, but many drugs. There are lots of drugs that cause alopecia. The most common, of course, being the antineoplastics, lithium, oral contraceptives, fluconazole. My cousin called me, her neighbor has San Joaquin Valley fever, which is coccidioidomycosis. She's had it for years. She was put on fluconazole. Her hair started falling out. So they had to lower her fluconazole dose and her hair started growing back. Here are some other hair disorders. Hair gain from drugs. In females, of course, giving androgens or testosterone-related drugs, you get hair growth in places where you wouldn't normally in a female get hair growth. Hypertrichosis is werewolf. This is where normally body parts that have short hair, like your back, your forehead, and your cheeks, start to grow hair. And as you know, minoxidil, that's in Rogaine. So this is what was used clinically to stimulate hair growth over the counter preparation called Rogaine. Learning point. Emergency department. Patient is prescribed 2,000 milligrams of IV vancomycin and 500 mLs of D5W. How many minutes should this IV run to prevent red band syndrome? Shima.
2 hours.
Yes?
2 hours.
Correct. Very good. 30 minutes for every 500 milligrams. 30 minutes for every 500 milligrams. Play safe, go higher. When it's somewhere in between, if it's 1250 is a common dose, 1250 milligrams. 750 milligrams is a common dose. 120 minutes. 15-year-old with mononucleosis prescribed an antibiotic for sore throat develops a rash. What's the most likely drug? Is an immune response? Can the drug be administered in the future? Ryan. Yes.
I believe that it's amoxicillin,
Correct.
and it can be.
The drug can be given. What about, is it immune response?
It's not an immune response.
Correct. It's a pseudoallergy mechanism, completely unknown. Okay. 62-year-old black female patient in the ED, swollen tongue, respiratory difficulty after starting lisinopril 2 days earlier. What's the diagnosis? How should it be treated? Kim. Correct. Yeah, she probably got admitted to the ICU. This tongue swollen that much, you better believe she probably needed to be intubated. What drug? The bradykinin receptor inhibitor. And as you'll still see Benadryl, epinephrine, and corticosteroid given in this case in every ED. It's a standard treatment. Maybe it won't be in 10 years when they realize it's actually doing probably no good at all. Although I would still give the Benadryl. Epinephrine, definitely, when you read Dr. Baumgartner's article, it doesn't help. Quickly, pruritus is a rash, is itching without a rash. Very common. Okay, let's talk about immunologic. Or shall we take a break? We'll take a break. We'll take a 5-minute break till 3:15. And then we'll finish up. And we're going to do a study group discussion towards the end. If those who want to stick around, we'll probably have to go beyond 4. But the study group questions are very similar to exams. For those of you who, I put on Blackboard the study group things, but if you want a printed version, it's up to you. You want to scroll along in it. So it's printed on both sides. So take one for each group. Otherwise, you can just pull it up on Blackboard when we get to it. I'll put it on the screen too if you want. When we get to it, I'll put it on the screen. Yeah, it's pretty standard. I never required any of this rationale for it. Actually, that's what you guys do. Without effort. But then there's also oh yeah, simple. So it's just a quick release, and then if you drop it, it's very patients they don't want to do it. Well, not so much itching, just that redness, flush feeling, and it's just very.
Yeah, that's one.
Well, you can imagine. You would give it just. Patients who give morphine, sometimes, and wherever it's injected locally, they get very kind of yeah, like, and it gets red and it does rage. Just Google search. Or Blue Man. Yeah, you know, it's amazing. Like I said, every single day. If you search the literature, you'll have all kinds of words. Rare, isolated. All right. All right. Let's start up again. We're going to switch gears now. Up to this point, we've been discussing all the non-immune, pseudo-allergy skin reactions. And as you can see, there were a lot of them, and there were a lot of drugs. And you notice with phototoxicity, there was both the immune and the non-immune reaction. And we're going to discuss another one in a minute, where it can be, well, the ACE inhibitor, we already discussed the non-immune ACE inhibitor angioedema. There's also angioedema that is an immune response, not related to ACE inhibitors. Okay, so an immune response, by definition, it's a reaction to an antigen, in this case a drug or a chemical, that results in an exaggerated response. Drugs or their metabolites can act as haptens, binding to peptides to become immunogenic, inducing cell-mediated or humoral being antibodies or chemicals, immune responses. Have you studied Coombs and Jones yet? Mechanism? No? Okay. So the immune mechanisms are divided into basically 4 categories. And these 2 gentlemen, Coombs and Gell, developed this table. It helps explain, but it's not a completely neat package. There are some other idiopathic immune responses, but for the most part, it's pretty accurate. And with each of these immune reactions, we're going to discuss what type they are. Notice type 1 is the immediate one. That's the one when somebody's given penicillin and they get short of breath within a couple of minutes of the administration, and without epinephrine they die. That's anaphylaxis. That's immediate, within minutes usually. The angioedema can take a little longer. Angioedema, the swelling of the face, and in the case of angioedema from immune response, you get swelling of the hands and other parts of the body as well, not just the face. Remember, ACE inhibitor was the tongue, the inside of the mouth, the lips, and so on. You'll see some examples in a minute. The type 2 is IgM and IgG mediated. Those are the immune globulins and complement that are involved in the type 2. The onset is very, very early, days to weeks. Type 3 and type 4 are more common. Again, type 3 is IgM and IgG with complement. And it has a fairly delayed onset, 1 to 3 weeks, as compared to the one they call delayed, type 4, which is T cell activation or sensitization. And that can appear in 2 to 7 days. So you've got the immediate, type 1, variable type 2, which immediate is IgE mediated. It's the only one that's IgE mediated. IgM and IgG involve 2 and 3, type 2 and 3, and then the cellular is the type 4. That's a kind of an easier way to remember it. And see, this onset gives you a clue as to the type it might be. Here's just a pictorial of what we just said. The type 1 anaphylaxis, IgE, and then type 2 and 3 being the IgG and or IgM antibodies in this area here, and then lastly is the T cell activation. All right, immunologic cutaneous reactions. These are the more common ones. You're going to get redness, you're going to get edema, you're going to get itching. Typically, as we mentioned before, they're maculopapular or they're morbilliform. Those are the 2 most common morphologies. They're usually benign, In a severe case, they can exfoliate. Get this, they start on the trunk, may involve the extremities and body foldings, but they often spare the face. So if somebody comes in and has a rash on their arms and their trunk, you're more suspect of a drug than anything else. And it's not on the face. If it's on the face, you're thinking of other things, measles, viral infections, and things like that. And as we mentioned before, any drug can probably cause this type of reaction, and it's usually within the first week of therapy. Again, the most common drugs are penicillin and the sulfa drugs, as we mentioned before. And the types, these are the terms that are given to the types of these so-called benign reactions, but they can range from mild to severe. They're not always benign. Urticaria or hives, usually in association with angioedema, and commonly associated with anaphylaxis as well. So you can get the fixed eruption, which is pretty innocuous. A good friend of mine, pharmacist friend of mine, we used to go to Ensenada, and of course we went to Husong's bar and had a little tequila. And the next morning, he'd wake up with a fixed eruption on this wrist, and I think it was one on the forearm. Same place every time. He says, every time I drink, this happens. He says, I think I'm allergic to alcohol. I said, you're allergic to alcohol? What he was doing was he was taking, to prevent the hangover, the next morning, he would take Fiorinol. You know what Fiorinol is? Anybody? It's a combination of either aspirin or acetaminophen with butabarbital. Butabarbital causes fixed eruptions. So he was taking the Fiorinol. All this time he thought he was allergic to alcohol. He was really allergic to the Fiorinol. Stop taking it. Acneiform, as we mentioned, is a type of reaction. Psoriasiform, which means it looks like psoriasis. Purpura, that's the bruising, the vasculitis, and the angioedema. We're going to discuss some examples of these. Now, these skin reactions, once they go beyond the skin, and this is where you refer the patient to a doctor. This is urticaria with angioedema, so the symptoms become systemic. And these are usually very severe, serious allergic reactions. Angioedema, bronchospasm, laryngeal edema, which is stridor. The term stridor stands for like Darth Vader. That's stridor. You'll never miss it. You had your physical assessment class, right? PPC? No, you haven't had that yet? We'll talk about that in pulmonary when you do the pulmonary. I teach the lung part. Serum sickness-like reactions include fever, urticaria, erythema multiforme minor. The key word here is minor. Arthralgias and lymphadenopathy. Lots of drugs cause it. Common ones you might think. Hypersensitivity vasculitis is two kinds. A mild form, cutaneous, and then when it spreads to the internal organs, it's visceral. Now we're getting into the really serious ones. Drug-induced lupus. Drug rash with eosinophilia, there's the key word, eosinophilia, and systemic symptoms, duress. Then last and most severe, blistering and or exfoliating reactions. Pemphigus, which I'll show you some examples. Erythema multiforme major, not minor, major, also known as Stevens-Johnson syndrome. It's just another name for Stevens-Johnson syndrome. And toxic epidermal necrolysis. You all heard of this one? Okay. These pictures get kind of gruesome, so I apologize. And there's some of the drugs that cause that type of severe allergic reaction. Now, here's what I was just telling you about. Here's angioedema, but an immune response. It's usually swelling of the face and hands, and it's usually associated with urticaria. Not always, but usually. As we saw in the first few slides with the kid with the peanut allergy. He had the urticaria and angioedema. So the swelling of the lips, the face, around the orbit of the eyes, which you didn't see with ACE inhibitors. There's no swelling of the tongue. There's not always swelling of the lips. And there's swelling of the hands. So that's how you kind of differentiate it from ACE inhibitor. Here's some of the drugs: NSAIDs, bupropion, SSRIs, statins, PPIs, protein pump inhibitors. And it can be life-threatening, and usually is if it's associated with urticaria and anaphylaxis. It is an immediate reaction mediated by IgE. Immune response, usually within minutes to hours. Stop the drug, give antihistamines, give corticosteroids. If it's severe respiratory distress, epinephrine is required. And that's given IM or sub-Q, usually IM, 0.3 milligram. You know the auto-injectors for bee stings and that kind of thing? Same principle. Those auto-injectors, EpiPen, contain epinephrine. But in a pre-measured dose. It's usually 0.3 milligram and for up to a half a milligram, but usually 0.3. Here's dress. Dress looks nasty. It looks like a maculopapular all over the trunk, but it spreads to internal organs, usually the liver, and it's characterized by eosinophilia. One of our faculty here, her mother developed dress. I forgot what drug it was, but the most common agents are anticonvulsants, which we'll discuss in a second. So if you got rash and fever and lymph node enlargement and this ugly looking rash, and you have involvement of the liver and the kidneys, most often the liver, you can experience a mortality of up to 10% if it goes untreated. Particularly with a lot of multi-organ involvement in the abdomen. Several weeks for onset, there's been a lot of drugs implicated. The most common are the sulfonamides, minocycline, allopurinol, the aromatic anticonvulsants, phenobarbital, carbamazepine, phenytoin, lamotrigine, and some HIV drugs. It's easily treated, fortunately, with corticosteroids and supportive care. With that kind of treatment, the mortality is probably much lower than 10%. So that's dress. It's sometimes called a great clinical mimicker because it can mimic a lot of things. It's also called hypersensitivity syndrome and a convulsant hypersensitivity syndrome and so on. It's got many names. Dress. Notice severe cutaneous allergic reactions called SCAR. This is known internationally as there are SCAR criteria for rating different severe drug skin reactions. You can look them up. Here's hypersensitivity vasculitis. This is inflammation of the blood vessels. Here's a person's arm, or it might be their leg. Can't tell if that's a thigh or what that is. There are two forms. There's the cutaneous form, which is milder. Type 3 immune complex mediated. You get these purpuric lesions, bruises basically on the legs. Antibiotics, propylthiouracil, allopurinol, thiazides, and other drugs have been implicated. Then there's the systemic form, which is much more severe, with fever, arthralgia, which is joint pain, myalgia, which is muscle pain. And then it can affect the internal organs and also the central nervous system. That's when it gets pretty severe. Usually, again, it starts within a few weeks, as you would expect from a type 3 reaction. Recovery is quick, usually without any significant sequelae unless there's a lot of internal organ involvement. So corticosteroids, sometimes you have to give an immunosuppressant if it doesn't respond well to the corticosteroids. And that would be azathioprine is the immunosuppressant called Imuran. All right, here's one of the last ones, near the last ones we're going to talk about. Notice the little blue arrows. Stevens-Johnson syndrome is in the SCAR criteria. It starts with erythema multiforme minor, which is a skin reaction in itself. Most common cause, viral infections, particularly herpes viral infections. But Stevens-Johnson and toxic epidermal necrolysis are a continuum that progress, getting worse as you progress down from minor to Stevens-Johnson, which is erythema multiforme major, to toxic epidermal necrolysis. 20% of erythema multiforme minor are caused by drugs. Now, if the drug is not recognized as the culprit, and the drug is continued to be taken in the face of fever, flu symptoms, and these usually occur shortly before these rashes. And the reason it's called erythema multiforme is because it starts like this, over here on the left. Where's my cursor? Over here on the left, see these little bumps, little papules. Then, and it's extremely itchy, then it progresses to these target-like, hive-looking, urticaria-looking lesions. And then in a few more days, it progresses to this, where you get these larger raised red bumps, still itching. So note, there's these three different morphologies for erythema multiforme minor, hence the name, as it progresses. Now, if the drug is continued to be taken, not recognizing that it's the drug that's causing this, then you get erythema multiforme major, or Stevens-Johnson, which is just a more severe, extensive form of erythema multiforme, and it most frequently is drug-induced. So the viral infection that caused erythema multiforme minor, usually that's as far as it goes. It never goes to Stevens-Johnson syndrome. It's drugs that cause Stevens-Johnson. And the Stevens-Johnson is evidenced by blistering, mucosal involvement, like here on this man's mouth, and exfoliation of the skin. Looks like a burn. That's what it looks like. Now, Stevens-Johnson, fortunately, is very rare. 3 to 6 per million population. It's a mixed type 3 and type 4 immune response. It has two things going on. The prevalence, there are about 300 cases diagnosed per year. There are probably more than that. I was working in the hospital about 6 months ago, and a lady came in, 26-year-old lady with Stevens-Johnson, and it had affected her, not only the mucosa in her mouth, but in her genitalia as well. And so she was a sick puppy. And she had started on an NSAID, ketorolac, which is an injectable. Have you studied ketorolac yet? Toradol? No? Okay, when you get the NSAID, it's a good pain medication. It's non-opioid pain medication, but it's a non-steroidal. It's almost as effective as morphine in certain situations. Anyway, she was on that for quite a few days and continued to take it in lieu of developing a rash and flu-like symptoms. She thought she had the flu, so she was given Tamiflu. She didn't have the flu. She had erythema multiforme, which progressed to Stevens-Johnson syndrome because she continued to take the Toradol. They did not recognize that it was the Toradol causing her symptoms. So you suspect in 1 to 7 days of starting a drug, if they get flu-like symptoms, which is, a lot of people get flu-like symptoms, so it's hard to differentiate. But if they get a rash in 4 to 14 days, suspect a drug. In fact, suspect any drug that was started in the last 2 months, because it's a delayed reaction. Mortality can be anywhere from 5 to 15% if there's adequate treatment. And look at this poor man. He looks like he was burned in a fire. Stop the drug immediately, obviously. Treat as a burn patient. These patients get hospitalized, as did this patient in our hospital. You give fluid, you give electrolytes, you give nutritional support. You treat it just like a burn with non-adhesive dressings, anti-infectives, pain medication. Steroids and intravenous immune globulin, worthless. Do not shorten the course of the disease. It takes a few weeks to a month or two to get over this because the skin has to regenerate once the drug is stopped. Also, note, there is a phenotype that puts you at risk. HLA B75 and B58. Viral infections, slow acetylators, and immunosuppression make you more prone as well to SJS. Here are some of the medications traditionally known to cause SJS. This is going back 50 years. Allopurinol, NSAIDs, sulfonamides, nevirapine, the AIDS drug. Notice it's in red because it has a black box warning for SJS. Penicillin, cephalosporins, barbiturates, lamotrigine, carbamazepine, and phenytoin. Those are the traditional drugs. There are 20 others, and there's some being added every day. I just told you about ketorolac. There's a recent report internationally of sertraline, number of cases from sertraline, a number of cases from the protein pump inhibitor called Protonix, and a number of cases from tramadol, which is an opiate-like drug, supposedly not addicting, but it is. Orally acting drug called Ultran. Notice the ones in red, lamotrigine and carbamazepine and nevirapine, have a black box warning for SJS. The one at the bottom, this is interesting, this is recent, the last couple of years, acetaminophen. The most widely taken drug in the entire world. Fortunately, or unfortunately, a very rare SJS has occurred with acetaminophen. 6 cases that I know of that are reported in the literature. This is one of them. Usually it's fairly mild. See, this one didn't have a lot of blistering. It did get the erythema, the later stages of erythema multiforme with those big red blotches. But there was some mucosal. Now, here's the worst case scenario. Continue to take the drug and you have Stevens-Johnson syndrome and you get toxic epidermal necrolysis, which is just a more severe form of SJS. Fortunately, even more rare because hopefully by the time you get SJS, you've stopped the drug, right? But obviously in some cases they did not and the drug continued on being used. This one you get basically third-degree burns over greater than 30% of your body. And every single mucous membrane, the mouth, the eye, and the genitalia are affected. You get what's called a positive Nikolsky sign. Here's what it looks like. Movie time. Those are the credits.
Okay, so you see a blister here. This is a shallow blister of pemphigus.
This is pemphigus vulgaris.
If you push on it, well, so we're seeing a negative Asbo-Hansen sign because the blister is not extending. But if you push on it, you see this is Nikolsky sign, and then basically it's a popped blister. And the whole point is the skin wouldn't move here if there's no blister because it's nice and attached. But once you have detachment, either in toxic epidermal necrolysis or in pemphigus vulgaris, you see that the skin moves, and that's the Nikolsky sign that I've just demonstrated.
Ugly, yeah. So with toxic epidermal necrolysis, the skin's basically peeling off. Same drugs that cause SJS can cause TIN. Mortality can be quite high if they don't get hospitalized. Here's the poster child. This is a woman who, I think she's in her 20s, in England, who was taking paracetamol. Do you know what paracetamol is? In England, that's their generic name for acetaminophen. She was taking acetaminophen, developed TIN, pretty severe, and this is her after. She recovered. Took her 6 weeks to get back to normal. Okay, here's a drug information question. Got your computers there. Find the latest drug reported by the FDA to cause Stevens-Johnson and toxic epidermal necrolysis. First person to find it, let me know. Raise your hand. I'll give you a hint. It was 2013, I think. Anybody find it? Yeah. Correct. Is that it? Is that the one you found? Yeah. It's a benzodiazepine anticonvulsant drug. I think it was marketed in 2012. And it carries the warning for SJS and TINS. Anticonvulsants, they're a big group when it comes to SJS. Big cause. Here's a special case. This one you need to remember. Because if you start anybody on lamotrigine, it has a black box warning for SJS and TINS. The prevalence is much higher, 1 to 1,000 in adults. Remember I said like, what is it, 6 per million with all drugs? And just this drug, it's 1 in 1,000 adult and 1 to 100 in children. Oh my goodness. Very specific titration schedule. The package insert is like 10 pages long. It details, in great detail, how you start somebody out on this drug. Particularly if they're a child or an adult, they have different schedules for each. The risk of SJS and TIN increases when you use higher than the recommended dose. You rapidly escalate the dose, go outside the limits set by the package insert. I think you increase it like once a week at a certain rate. Or, here's an important one, give it in combination, which it commonly is, given with valproate, which is another anticonvulsant. Valproate doubles the half-life by blocking the metabolism. This is a drug-drug interaction of the lamotrigine. So when you counsel patients and they're starting on this, if you're doing the parent or the caregiver or the adult, make sure they understand they are to follow the prescribed dosing exactly. And do not stop or restart without calling the doctor or the pharmacist. And tell them to discontinue at the first very sign of a rash or maybe even the flu-like symptoms, although those tend to be nonspecific. All right, special case. Blistering drug eruptions, not too common, but there's pemphigus, which you saw on the YouTube video, pemphigus voliceus and vulgaris, and you get this blistering and these red, disgusting looking blotches. The most common drug is penicillamine, which is not used much anymore, but it's not penicillin, it's penicillamine. It's a binding drug, binds copper or something. Captopril, ACE inhibitor, and other drugs. In fact, up to 7% of patients put on penicillamine will develop pemphigus. Here's a bullous pemphigoid type reaction seen with ACE inhibitors, sulfa drugs, again penicillamine. These are big bulli. See this erythematous area, this reddened area underneath? That's characteristic of bullous pemphigoid. There's an ethnic predominance in Ashkenazi Jews for some reason. Again, probably a genetic factor. And it has an immunologic autoimmune antibody mechanism. Don't know if it's type 3, 4, 2, but it is an immune reaction. You give oral corticosteroids, you can give immunosuppressants and then IVIG to treat it. They will go away generally. Some may persist after stopping the drug. This one just has blood in it down here. Then there's psoriasiform skin eruptions. You can either have them drug-induced, where the patient has no history of psoriasis, and the drug will actually precipitate psoriasis. Beta blockers, lithium, interferon alpha, ACE inhibitors, and here's a TKI, a NIB, that can cause it. Notice the drug aggravated. This is a person with a previous history of psoriasis, and it just progresses the disease further. Notice it's all basically the same drugs as up here, with the exception of the beta blocker and the NIB. So it's either provoked by drug inducing, no prior history, or it's aggravated with prior history. Lastly, genetic metabolizing enzymes are found in the skin, as we mentioned, and slow acetylators are much more at risk of developing drug-skin reactions. And remember, the skin has drug metabolizing enzymes. So these are the genetic considerations. You got your HLA phenotypes, and as an example, the nevirapine that we mentioned earlier causes a lot of skin reactions, particularly in HLA-B3505. And we're going to talk about some more examples on the next slide. But here's drug-induced lupus, which also has a genetic component. It's more prevalent in slow acetylators and HLA-DW4. There's a common term for this facial rash. It's called wolf, like the wolf, the animal, mask. You all know what lupus is? It's an autoimmune disease that affects connective tissues and other organs. Usually affects the kidney, and usually in females, and it can strike at an early age. I had a friend was in elementary school, and she died at age 26 from lupus, from the kidney failure. This is many years ago, before we had good kidney transplant procedures. The onset is really delayed. It can be months to years. Starts with a rash, the fever, muscle ache, joint ache, and there's no prior history of any autoimmune disease. This is completely drug-induced, and the most common drug is hydralazine, drug used for blood pressure called apresiline. That's the brand name, but the generic name is hydralazine. Procainamide, which was Pernestal, which was used for cardiac arrhythmias, isn't on the market anymore here in the United States. It is still available for special cases. Isoniazid and other drugs. The treatment, again, is corticosteroid creams and NSAIDs. That's drug-induced lupus erythematosus. Now, lastly, some drugs that we really need to concentrate on genetics considerations. Allopurinol. It's been associated with these serious reactions with HLA-B5801. Carbamazepine, you must screen Asian descent before this drug is started. And if there is a HLA-B1502, the drug cannot be given. And the last one is the Abacavir AIDS drug. In HLA-B5701, you can get hypersensitivity syndrome or DRESS, as we talked about. And you need to screen for this phenotype to avoid that reaction, which can be fatal. All right, we've run the gamut. Now, keep this for future, this whole PowerPoint for future reference, because I've included a lot of information on here that can be useful in your rotations. Okay, last learning point. Recognize that? What is the most common cause of drug-induced lupus? Joanne. Most common cause. Hydralazine. Very good. Yes, it was on the previous slide, right there. Hydralazine. All right. Conclusion. Importance of recognizing cutaneous reactions early helps prevent problems down the road, as you can see. Be able to describe the morphologies of the skin reactions, maculopapular, fixed eruption, mobilliform. Be able to differentiate between immune and non-immune. Know the main culprits. How do you treat it? How do you prevent it? Know certain counseling points with respect to certain drugs. Understand how genetics play a role. And know when diagnostic testing is indicated. It's not always indicated. And as I always like to tell every student, all drugs are poisons. You can drown from water. So, but all drugs are poisons, and I mean that in a sort of serious way. If a drug doesn't have any pharmacologic or any side effects listed, and there isn't a drug on the market that's the case, it's a true pharmacologic agent, it has no therapeutic effect. Think about drugs as chemicals that interact with body chemistry. They're disrupting the normal processes or affecting the normal processes. So all drugs technically are poisons, even in therapeutic doses. I've given you a bunch of references. Any questions? We're gonna try to do the study group thing in 20 minutes. Did you all gather? Did each group get one of the handouts that I have? If not, I'm going to bring it up on the screen anyway. So. Let me find it first. The study group discussion has questions that are similar to what you'll see on the exam. Okay, I'll give you like 5 minutes to work on it, and then we'll go through them. Let's see what I did with my here. Key. So each group, just answer the questions. You can write them down on a piece of paper, and then we'll run through them one at a time. So here's groups 1 question about a viral infection and the rash. And here's group 2, and so on. The answers to these will all be found under slides. You don't have to use any other reference. Okay, so at 5 minutes to we'll start. Unless you want to start now. We'll start now. Up to you.
Can we start right now? Yeah.
Sure. Let's do that because I wasn't expecting to have that quiz today, so that kind of puts us behind. But anyway, okay. Turn to slide 38 for the first one. Now I will send you on Blackboard. I'll post the slides I used today with the different questions. Okay, so you got a patient with a viral infection and develops a rash 2 days after starting therapy for sore throat and infection. What's the morphology of this rash you see here? Is it maculopapular? No. Is it fixed eruption? No. Is it a pustule? It's morbilliform. That's a measles. It's a very faint rash. It's kind of hard to see, but okay, let me. Can I enlarge this? Probably not. Oh yeah. It's a pretty mild rash, but it's all over his body. It's hard to appreciate that it's all over his body. Whoops, too small. So it's a morbilliform, measles-like rash. What drug is most likely to cause this? Anybody? Amoxicillin or ampicillin. Ampicillin isn't prescribed as much as amoxicillin. So what was the predisposing factor that caused this rash? What was wrong with this patient? What other comorbidity did he have? What was the disease? He had mono, right? He had a viral infection. Epstein-Barr. Can he get this amoxicillin 2 years from now if he doesn't have mono? Yes, he can. He's not allergic to it. How could it have been prevented? Possibly by doing a mono spot test and know that the guy has mono and not prescribe the amoxicillin. Give something else for the sore throat or the throat infection. And to treat it, you just stop the amoxicillin. Okay, group 2. Describe when skin testing for a drug reaction describe when skin testing for a drug reaction may be appropriate. You all mentioned it earlier. It would be when somebody needs the drug and there's no alternative. And usually skin testing is only done for the severe reactions like anaphylaxis. You wouldn't do skin testing necessarily if somebody just had a rash from a drug. You would do the graded challenge if they had a rash, where you use small incremental increased doses given orally and observe the patient over a period of hours or days. When do you do desensitization? Again, when you need to get the drug. It isn't done all the time. There are, like I say, you go online and you'll find all kinds of desensitization protocols. For penicillin, carboplatin, cisplatin, and a lot of other drugs. So if the patient really needs the drug, and it's the kind of drug where you're going to get it in intervals, like in chemo drugs, it cycles. It could be every 3 weeks, every 4 weeks. Then you mix up intravenous bags, starting with a very small dose of the drug, like carboplatin. Then you keep doubling. The next bag has twice as much, and then so on until you've given the entire dose, which could take up to 8 hours. So that's desensitization. And it's done intravenously, not orally. The graded challenge is done orally. So the 3 drugs I just mentioned for desensitization, carboplatin, cisplatin, and penicillin are the most common, but there are others. If the penicillin skin test is negative, is it always safe to give the penicillin? No, because 10% of the time, they can still be allergic. I haven't seen that skin test. Maybe allergists still use it, but I haven't seen that skin test used in years for penicillin. 3, the patient comes to your pharmacy with a skin rash that looks like this one. What type of rash is it? What's the morphology of that one? This is probably on the trunk of the patient. What would you call that? It's not morbilliform, right? So what's the other one? It could be a cross between hives, urticaria, maculopapular. Although all of the bumps are kind of raised, so it's probably more like a hive than a urticaria. What questions would you ask this patient? Hey, I got this rash on my arm. Yeah, you're going to ask them, did you start a new drug lately? Have you ever had this reaction before? And let's say they say, oh yeah, I just started a Keflex 4 days ago. Oh. So what would you treat that with? Antihistamine, most likely. The only over-the-counter thing you can give. If it were more severe, then you would have to refer them to a doctor for steroids or other pain medication if it was pain. Now, if the patient came in and said, I have fever, my joints are hurting, I got this rash, and what would you do? Refer. That's pretty serious. When there's systemic symptoms other than just the skin rash, that's more severe. 4, name 4 drug-related risk factors. That would be slide 11, 12, and 13. Or actually slide 11. Go back to slide 11. So what are the drug-related risk factors? High molecular weight. What else? Functional groups. These are related to the drug, not the patient. route. The most antigenic is topical. Are you ever going to recommend Benadryl cream to anybody? No. Don't. Frequent, prolonged, multiple exposure. And then the dose. Particularly if it's a drug that's not a pseudo-allergy type thing where it's just toxicity. Okay, well, we got the slide up here. What are the risk factors that are patient-related? Mm-hmm. Right. Right. Certain phenotypes put you at risk. Slow acetylator put you at risk, and that is Asian descent as well. In history of multiple documented drug reactions, skin drug reactions. That's an excellent test question. So what are the main culprits? What category is the most common? Anti-infectives or antibiotics. I say anti-infectives because it includes more than just antibiotics. True antibiotics. Anticonvulsants. Radiopeptides. And within the antibiotics, it's going to be the penicillins, the sulfa, and the cephalosporins and other beta-lactams like the carbapenem drugs. NSAIDs, HIV drugs, cancer drugs are the more common culprits. What's the difference between phototoxicity and photoallergy? Yeah, one's immune, one's not. And there are characteristics that are different for each. The toxicity comes on within minutes, after just minutes of exposure. It can be dose-related, whereas the allergy doesn't have to be dose-related, but they have to be exposed first before it doesn't occur on the first exposure to the drug. Which one's more severe? Photoallergy or phototoxicity? Photoallergy is more like a dermatitis. The phototoxicity is more like a sunburn. And it's only on the skin that's exposed areas. And if you protect yourself against the ultraviolet light adequately, the reaction doesn't occur. So you can continue to take the drug. Whereas in the photoallergy, you can't take the drug ever again. The reaction will get worse each time. List 3 drugs that can cause skin pigmentation. One you don't want to forget is amiodarone. Brand name is cortisone. A lot of other drugs can cause pigmentation. The antimalarials, anticonvulsant phenytoin, minocycline, some chemo drugs, oral contraceptives. In the case of oral contraceptives, the rash is usually, or not the rash, the pigmentation is usually pretty mild, but it's cosmetically not agreeable. Let's put it that way. So amiodarone is the Smurf man. It's a toxicity-related phenomenon, dose-related, takes months to go away. So if you were to counsel somebody on these drugs that cause reactions to the skin that are exposed to ultraviolet light, what are you going to tell them? Stay out of the sun if you can, and sunscreen, 15 or greater. Yeah, wear a really good hat. Not a baseball cap. And if it's somebody who has to work outdoors, they need to cover up everything. There was a drug released by Eli Lilly, I think it was in the 80s. It was called Zomax. It was a non-steroidal anti-inflammatory drug. The drug, when it was marketed, came with a package insert that was literally a book. It caused gray changes, pigmentation in the eye. It caused fingernails to fall out. It had so many side effects, I don't know how it got past the FDA. Within 2 years of marketing, it was pulled off the market because there was deaths and liver toxicity experienced in Europe. Eli Lilly was the biggest generic manufacturer in the world. Eli Lilly usually buys patent rights for drugs in Europe, Japan, and China that aren't marketed there. They buy the patent rights and then market them here. To disastrous consequences. 6, red man syndrome, right? Caused by? Right. Giving the vancomycin too fast. What dose of warfarin do you never want to go higher than on the first dose? Good. Usually start at 4 to 5. First time out, no matter how much they weigh, how old they are, give them 4 or 5 milligrams. Now, if they have liver disease, severe congestive heart failure, you start at a lower dose, 2 milligrams. Because where are the clotting factors made? In the liver. IV contrast, is that an immune response or pseudoallergy? The IV contrast or pseudoallergy. It's due to mast cell degranulation with release of histamine and other inflammatory mediators. What limits the use of Xeloda or 5-FU oral for cancer? That one. Hand-foot syndrome. Be able to differentiate the gel-coon types. Type 1, immediate, IgE. Type 2 and 3, IgM, IgG, and complement. Usually a more delayed response. And then type 4 is the cell-mediated. You don't necessarily need to know those for each drug, but just know that the immediate reaction is the one that causes anaphylaxis, angioedema, bronchospasm, and life-threatening reactions. Patient comes into the ED and looks like this, and is on an ACE inhibitor, it's an ACE inhibitor causing it. There's no doubt about it. You'd have to give a bradykinin, if it's really severe, a bradykinin inhibitor. Bradykinin inhibitor. And epinephrine doesn't really work in the severe cases for the respiratory distress. You've got to intubate the patient, put him in ICU. And changing to an ARB, angiotensin receptor blocker, doesn't always work. The homologous skin things are the nails, the hair. And then be able to do, when you get to the scar, all of those serious cutaneous allergic reactions. There's the angioedema again from an immune response, not due to ACE inhibitors, due to other drugs. A lot of other drugs, actually. and also peanuts. Or actually, a lot of food allergies, you'll see this. The DRESS syndrome. The hallmark is eosinophilia. The other serious ones you don't see, eosinophilia. Eosinophilia means eosinophil count is very high. Your eosinophil count is around 2% of your white cells. In this condition, it can go 10, 20, 30%. Very high. And it affects other than just the skin. It affects the liver. And then remember, this is a continuum. Erythema multiforme minor to Stevens-Johnson to TEN. It's a continuum. It's not 3 separate diseases. It's just a progression of more and more severe reaction to the drug. And you all saw the Nikolsky sign, right? The highest mortality is in the one you would expect, toxic epidermal necrolysis. They all can be fatal if not treated. Most patients would survive. I mean, a lot of burn patients, if it's not over too large a portion of their body, will survive with supportive care and hospitalization. All right, did we cover them all? I think so. All right. Any other questions? I think I have, I don't know the final count, but I think I have 4 or 5 exam questions. I think most of them are multiple choice. There might be one true false, maybe one fill in. Remember, take the slide, make a question. You'll probably get the right one.